With all the conversation on social media around whether internal work is the gold standard in pelvic health therapy, I felt the conversation needed to head in a slightly different direction. And that is why I invited Laura Rowan, an occupational therapist and educator, to sit down with me today so that we could discuss the more important question of, are we actually training clinicians to work internally in a successful and safe manner? Together, we had a candid conversation about what pelvic health education could look like and the changes that could be made to help our profession do better. In this conversation, we discuss what success with internal work looks like, the importance of trauma-informed education and true consent, the must-haves in intravaginal education that every practitioner needs, why knowing how to assess is only half the equation, what to treat beyond the pelvic floor muscles, and how to turn clients from passive recipients to active participants in their treatment. Internal work is a tool, not the entire treatment. The real skill is knowing when to use it, how to create safety, how to interpret what you find, and how to turn those findings into effective treatment. Tune in to today's episode and let's raise the standard for pelvic health education. Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Hello, everybody, and welcome to this podcast episode. Boy, do I have a treat for you. I'm sure you are aware of the plethora of information happening and conversations happening on social media about the gold standard of pelvic health therapy. And Laura, actually, I wrote an email and sent out my take on this whole situation. And Laura replied back to me and said, "Oh my gosh, Lynn, let's talk about the education of these pelvic health therapists, learning to do intravaginal work. And let's talk about the gold standard of that education." And because that was a huge piece of what I talked about in my newsletter. So Laura Rowan, thank you so much for being here. Laura is a occupational therapist, a pelvic health therapist. She is the owner of Essential Pelvic Health, and you're on the East Coast, Laura. I forget exactly, Pennsylvania. I forget where.
I'm in upstate New York,
Upstate New York. Okay.
right on the Massachusetts border. So I am licensed in Massachusetts and New York. And yeah. I have my clinical practice as well as my educational company to be able to train clinicians to do this work.
Okay, so we today are going to dive into what we consider to be, we both agree that intravaginal work is the gold standard for pelvic health therapy. And so that's not on debate here. And we also are firmly agreed upon the fact that it must be done with the consent of the patient, with the patient's body on board, with, everything lining up before we do it. And so, that's not for debate here. But what we would like to talk more about is really calling out our profession in how we are actually training new providers coming into this pelvic health space. Because I have heard some stories that are appalling. And I personally do not like how the bigger companies are doing the courses for their intravaginal level ones, twos, whatever it is. And so Laura, what's your take on this? What do you want to start things off with?
Yeah. Well, I mean, I responded to your email, the huge debate email,
Yeah.
because I think it's the fact that we see these extreme conversations and languages and responses, they're like emotional responses to,
Yeah.
no, you shouldn't, or you don't have to be doing internal work. Yes, absolutely, everyone should get internal work. I mean, the extremes, of course, are not going to land, right? You
Right.
have to have that individualized care. And that's, when we say the gold standard is internal work, yes, and it's not for everyone. or it's not for everyone right away. Like there is a lot of
Yes.
nuance that we have to be considering. But to say one or the other, that's not going to really be able to treat the client in front of you. So
Well, and I
just
think a lot of those claims, if we really look at them, are to sell programs online. There is a motivation behind these bold claims that people are making, and we really need to look and understand that someone's trying to sell a program, someone's trying to sell a course. And Laura and I are going to be upfront here. We both sell courses. And we have a stake in educating other practitioners. And I feel like we are very aligned in what we subscribe to and what we do. And so we just really want to call out our professions and like let's really take a serious look at how we are bringing new therapists into this field, because how we treat our students is going to be trickled down into how the students treat their clients. And and I just want to share, a student was at my course and she went to a very large internal pelvic health course, and I don't know which company. There were 60, 70 people in the room. So they had the stage with the teacher up on the stage, and they had the two big screens on either side, tons of TAs around. And this student had a trauma response in doing the intravaginal portion of the course. So the instructor brings her up onto the stage and has her be the model in front of everybody.
which is insane.
Absolutely insane. I mean, talk about not being trauma informed. I'm like, so of course this poor person is freaking out on the stage and disassociating, and the instructor is oblivious to it. Well, she's not oblivious, but she was just so not um compassionate to what was happening to the student. And I'm like, if this is the way that we are treating new students, what are the students going to be doing to their clients?
Right.
Like,
Because not
it's
only is that clinician now traumatized and probably not going to be able
more.
to do the work, but also you're showing the other
Yes.
students that that's okay to just continue beyond
Yes.
and ignore all the signs, right? Not look for the signs. Like with my coursework, I ask ahead of time. I'm doing intake work just like I do for my clients. It's like the students, the participants, we are humans. We have to consider
Yes.
ourselves. So I'm making sure people understand what's expected, what's going to be happening, and they have an opt-in, right?
Yeah. Yeah.
If they really are not able to tolerate the work, but they want the training, we can, they're able to answer that question ahead of time, educational needs assessment, and then we can plan for that, right? So we
Right.
can make
Well,
accommodations.
yeah, and I do not make it a requirement for my courses. So my live pregnant or holistic pregnant and postpartum body courses both contain internal work. And it is not a requirement. Now, I have had some students go, "Oh, I'm on my period, so I don't want to
Yeah.
participate in lab," or "Oh, I just don't feel like it." I'm like, "Okay, that is not okay." And I'm going to encourage you to continue to do the lab. It's
Yes.
more, I don't want you participating in the lab if it's going to trigger you more and cause more trauma in your system. And
Right.
the way I teach entering into the vaginal space, there is four different check-in points to make sure that our client is actually still on board from the
Yes.
yes that they said in the beginning before they even got undressed. And
Absolutely.
and I had one client who she had a lot of trauma from IVF treatments. And IVF, you have to perform at the right time. There is no, I'm not feeling it today. Can we wait?
Yeah.
And it was from that she had all this trauma. And she was also had this really good Southern, I'm a good girl performer. And so I missed the cues until I touched the upper part of her leg. She's draped and I've got my glove on. I'm ready to go internal. I touched her upper by her knee, and I just got this immediate hit no from her
Hmm.
body. And I told her, I was like, Oh my gosh, I missed the other cues that I usually tune into, but I think she had such a good, I need this, I want this
Yeah.
done, I'm going to make this, I'm just going to buckle down and make this happen. But when I got there, I was like, we cannot do this. And she even begged. She's like, please, please, that's why I'm here. I want you to do the internal work. And I was just like, no, your body is not on board. And so I just continued with the external pieces of it. She came back the next session and she said, Lynn, that was the most powerful thing that has ever happened to me before in a medical setting. My body has never been respected like that before.
That's awesome.
And so that is the kind of skill that we need to bring to our clients to
Yeah.
help them to feel that safety, to feel that security in being able to do that. And I know you teach this in your courses as well. It's that learning how to read the body's yes and
Hmm.
not just the mind's yes. It's two separate different things.
Yeah, and I always have my clients like I will show them with my pelvic model, this is what a pelvic floor assessment could look like. And I use that language because they
Yes.
come like, no, just do what you have to do. I want it to get better, right? And I'm like,
Yes.
I have a lot of different ways outside. This is just one way to get information. I have lots of different ways to get information and to interact with the systems that can still move the needle forward. So I ask them, I'm like, check in with your nervous system. As I'm showing you this demonstration, do you get the red light or green light? And if you get a red light, I want to honor that because we're not
Yes.
going to get good, positive outcomes or information if we ignore that, right? We can't strong
Yes.
arm the nervous system. The thinking mind can want one thing, but the
Yeah.
nervous system is the boss. So I
Yeah.
always encourage that and support it because I know they're like, no, 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 I'm going to have to do this if I want to get better. And having that conversation right up front with our clients and then just think about like I explain that in my coursework so the students get that ahead of time so now
Yeah.
they can already apply it to themselves before they go into the live lab.
Yeah. I think that's so important that we learn the skills to be able to, educate our clients to help give them the sense of control
Yes.
and also then being able to tune into whether the body and nervous system are on board with
Yeah,
doing it and not just the mind. Because to me, sometimes those are three separate systems. You
for
know,
sure.
the mental is different than the nervous system is different than the vaginal space, the body level awareness of the tissues at that
Yeah.
level.
And the
And
thinking brain often gets in our way, right? It's
yes,
trying to
yes.
think of something that makes sense. And sometimes we just don't know what we don't know yet. And
Yeah.
so we have to just kind of get out of our own way and let it kind of unfold. And then we can start to make sense of it. But if we try to do
Right.
that too soon, we just come up with probably incorrect theories, right? And then we kind of go down in the wrong direction, which is, I mean, I think probably why it's so important to do the assessments because if you're doing the intake, we can get a lot of information. And I start
Mhm.
my theory from the intake and the symptoms and the
Sure.
descriptions and the movement that I can see, but it doesn't always match up to
No, it
the
doesn't.
internal.
No, it doesn't,
So
does it?
you
No.
have to you
Yeah.
have to be able to do as many complete assessments, really understand the mechanisms to understand the intervention. And
Yeah.
then you can help guide them forward in an informed way that is working for them, not against them,
Right.
right?
And it doesn't, that internal assessment does not need to happen right away. Like there
Mhm.
is a lot of trust building and co-regulation that needs to happen between you and your client. And that's why both you and I firmly believe that we should be working with our clients completely clothed before we do the internal work. Like I want to do external work with my clients first, hands-on, without them disrobing. That this is my approach. I'm not sure, Laura, you'll have to let me know yours, but I there's so much that we need to assess and treat externally before
Mhm.
we actually do any internal work first. And for me, it's like the pelvic bones need to be addressed first. That I
Yes,
will die
not
on that
dance around
hill. I will
it.
die on that hill that
Yes.
as pelvic health therapists, we are not, it goes beyond internal and or anterior and posterior rotations, everybody. It
Hmm.
is not enough to just treat, oh, they're in an anterior rotation, left ilium, or whatever it is. That addresses the top part of the pelvis. If your client has had falls or has given birth, that pelvic outlet needs to be addressed because that's where the pelvic floor muscle is attached to.
Right.
And so that is such an important piece that needs to be addressed beforehand. And by doing that, we're helping our clients get used to our touch.
Yes. Yeah. I start at the rib cage. Pelvic floor, respiratory diaphragm are best friends. So I tell them
Yeah,
I'm going to start, when I'm showing them the pelvic floor assessment, what it could look like, I'm like, I'm going to start at the rib cage. I want to see how you're breathing, how your diaphragm is moving, how your abdominal space is moving, what your core connection is. And so you're already co-regulating, getting your hands
yeah,
on them in a safe place that
yeah,
is nowhere near the pelvis, and you can already start to read what that feels like. And then when I say, okay, now we're going to shift to the pelvic floor. Is it okay if I start by looking? Is it okay if I lift this sheet up, right? You're still
yeah,
giving them
yeah,
even more. And I'm not even touching at the point. I'm observing. I go through a whole observation sequence and then external and then internal. And the whole step, every step of the way, they have
yeah.
opportunity and I have opportunity to see if
Yeah,
this is beneficial.
and Lara, I think, this is a skill that needs to be developed as we do more and more work with our clients. That I don't think it's a skill that we can learn. Some people might be skilled to do it right away, but it's the nuance of listening more to the body than just the yeses, because just like the example I shared, the body is like, or the person's willing themselves to get through it, or they're, just like so many of us say yes when we don't really want to.
Mhm.
So that higher level skill is really being able to tune into the body and get a sense from that nervous system and body level of, is the body really on board with this, not just their mind and their yes. Like I
Watching
say,
their breathing, watching their eyes. That's why,
yeah,
like, I also like to teach just different positions. Like, we have lots of different positions as the clinician
yeah,
and for the client. And I really like sitting on the table because I can see them better. I can see their breath. I can see
yeah,
everything, and I can communicate with them better rather than kind of being lower and not really having
right, yeah.
good visual contact. So,
Yeah. And so we've talked about the external piece,
mhm,
and addressing that, first, and really getting that connection, that client feeling safe with our touch. And, I tell my clients right off the bat, like, I do not want to create any pain in your body.
mhm,
Like that, like external or internal, pain is a signal to me that your body's not liking it. And it's, I don't want to create. Now, there is a difference. There is a nuance. If I'm working with scar tissue, a little
mhm,
stretchiness, a little burniness, a little, tension. I say, if anything feels too uncomfortable, please let me know. I don't want to create any pain. And if I can sense that there's a lot of tension underneath my hands, I'll check in. Are you okay? This seems like there's a lot of tension here, and help them, because there's that crescendo right before the release. It kind of builds up and then it releases and lets go. And so I want my clients to understand that. But my goal when I'm working with any of my clients, especially intravaginally, I don't want to create any pain. And so a lot
yeah.
of times with our clients with pelvic pain, that means not doing an internal assessment,
Sure. Yep.
right?
And be getting good at being able to interact with the structures through maybe the bones,
Right.
taking away the tension or the compression,
Yeah.
or with different movement or breath work, right? Being able to interact with pelvic muscles through the breath versus
Yeah.
internal.
And
So,
that breath work is working with the nervous system. So it's all connected. That vagus nerve is involved in that. So we need to have that greater capacity. So is there anything else? Like to me, these are the gold standards for doing
Yeah.
intravaginal work.
Yeah.
Anything else that you want to add to that? Yeah,
I, I,
definitely.
I think again, like from what I've kind of when I put together my coursework, I
Mhm.
I I said, what did I wish I had when I was
Yeah,
starting out? What did I
yeah.
want more of? And I think it's, there's in a lot of some of the kind of gold standard larger courses, there's a lot of theory and research, which we need, absolutely. But what I found, and what I still hear people, because a lot of people take intro courses and then they take my course, and
Mhm.
they're like, I got a lot of theory, but I didn't get the practical hands-on application.
Yes,
And then
amen.
the other big thing is the treatment interventions. Like I want to know, like, okay, I can assess it, but what the heck do I do with it? And I want to have
Right,
options, right? I want to
right.
be able to go, oh, that didn't work. Let me try this one. Let me try this one
Yes.
next.
Yes, absolutely. One other piece to before we dive into what we want the continuing education to look like
Yeah.
for me is in doing intravaginal work is the connection of my client to their pelvic space.
Yeah.
So, there's several different ways that I teach this, but just making sure that my client can connect into their pelvic space because there's so many women that have been experienced trauma of all different sorts, and they cut themselves off. Like their body is blocked. It could be at the diaphragm, it could be at the umbilicus, it could be, I had one person that I had to work up here because nothing got down past her shoulders. And I feel, and again, this is more advanced skill, yet the more connected a person is to their pelvic space before we do the intravaginal work, the greater success our treatment is going to be.
Yeah. And even into men too, right?
Yeah,
So
oh,
because I
absolutely.
work with
Yes.
all
Yeah.
genders, and
Yeah.
I had two great examples. They were two male general practitioners. The one general practitioner referred the one general practitioner, and then he's like, I want to come see you too. And it was funny because he was like, the one guy was like, I must have learned about this part of my body, but in med school, but it's like a black box. It's like we just
Yeah.
kind of check out. It does what it should do until it doesn't, and then
Right.
that's when we try to figure it out. And then I was working with a lung surgeon, like a respiratory
Uh-huh.
specialist, and he had a lot of anxiety and he didn't know how to breathe. He's like, I know how to do surgery on the lungs, but I don't know the mechanics. So it's like the mechanics, connecting the mind to the body
Yeah.
in
Yep.
the respiratory diaphragm, the pelvic floor, all these systems is foundational. That's the number one.
Absolutely. And making sure that our people are connected to that, being able to sense it and feel it and everything is so key because that helps us to make sure that our clients are connected and not disassociating.
Yes.
So we
Yeah.
need to also know and understand the signs and symptoms of someone disassociating
Yes.
and
Yeah.
then like not move forward, Laura, when they are
No, you stop.
disassociating. We
And you address it, right? You
yes.
help support them through that to understand what their body was doing and understand, like learning the signs, bringing the awareness to when they start to get dysregulated so they can start to
Yeah.
be empowered to kind of check back in and get regulated again.
Right, right. Okay, so now let's dive in because I think we covered all the gold standards for doing internal work. Let's talk about how we should be teaching
Mhm.
internal work to our new therapists because I think one of the biggest issues, COVID threw everybody for a loop. And I think that really changed how we were doing internal courses because there are very few internal courses taught with an instructor in one location and everybody in that one location. Um,
Yeah, yeah. And when I started teaching, it was because of COVID. It shut down all the large continuing education companies. So people were reaching out saying, how important is it to get this training before I get
Very.
started? I was like, oh, it's important. We don't, OTs and PTs, we don't get it in our curriculum. So we
No.
need
Yeah.
to get competency, right? So
Yeah.
I was like, well, I'll do it. And then that's when I got really excited. I was like, let me put in what I wish I had.
Yeah.
And I realized, especially from an OT perspective, we want to be respected and have a seat at the table,
Uh-huh.
but we also need to teach each other. We need to be teaching from each other. So I mean,
Yeah.
it's open
Yeah.
to OTs, PTs, and other, medical providers,
Yeah.
but I realized for OTs especially, we need to really understand within our own profession that we can and should be doing this work and to be learning from each other and supporting each other.
Absolutely, absolutely. So we are now going to dive into what we both believe should be the gold standard for internal intravaginal education
Yeah.
for therapists learning this work. And number one gold standard is in person. Like you
Yep.
can learn theory and concepts and all the research stuff, but the actual hands-on learning should be done in person. And I'm a big proponent of the teacher being in the room.
hmm Yep,
Um,
that's
that's gold
I'm
standard here,
I'm
you know?
structured like that. We also know accessibility. We want to make sure like
Yeah,
not everybody
yeah.
can, but yes, absolutely. I think, especially if it's your first internal course,
Yes, yes.
like
So
that
so
really needs to be.
right. Those therapists who are wanting to get into pelvic health and have not done any intravaginal course,
Mhm.
that training should be done in person with the instructor in the room, with TAs available depending on the space. Well, ideally, the gold standard is small classes too,
Small group. Yeah. I
small
mean,
groups.
I I can see it going larger if you have multiple instructors and a lot of
Yeah,
TAs.
yeah,
But really, I still find, in a 40 plus group, it's easy to get lost.
yes,
And,
yeah.
I mean, I feel it's a sweet spot with 20
Me too. Me
20
too.
or less,
Yeah, yeah.
and really just, I'm like, if I'm wondering if I should add another TA, I just add them,
Do it.
right?
Yeah,
Because that
yeah.
just makes such a big difference, and every TA adds so much to the group.
Absolutely. Yeah, their experience and they're adding absolutely. I love that. Yet what's currently happening and I think the problem is that pelvic health continuing education companies should be run by pelvic health physical therapists or occupational therapists, right?
Clinicians, yeah, absolutely. Yeah,
Clinicians who are in the space because we know
yeah,
that's not happening in one company and the quality of their education, what therapists are getting out of it, I think is detrimental to our profession. I'm just
yeah.
going to call it out. I mean, having all those satellites and the TA, so pelvic health therapists who are wanting to learn and get into this field, you want to make sure who's going to be training you when you sign up for a course. Because a lot of times with these satellite courses, it's one other person who's a lab assistant who's taken the course once and maybe has attended a training with the instructor one other time. Like it's not quality training that you're getting there.
Right.
And you need to know what you're signing up for. And I would encourage you, like spend the extra money and go fly to be in person with the instructor in the room
Yeah.
and find
And
those smaller courses.
yeah, and like for my instructors, they go through a teaching training program. They've TA'd, so they've had extensive exposure.
Yeah.
Like you
It,
said, not just once. And because I remember when I TA'd for other courses, and I was like, I don't know if you really want me as a TA. I just took this course, and they're like, Nah, it's fine.
right?
So,
Yeah. Yeah.
uh,
That's not
but
like
yeah.
the TAs in my courses, they're all certified. Most of them, I think they've all been certified. And so they've taken my certification track.
Mhm.
And so they've been doing the work for a while, and I know through that certification process that they understand the work, and they are in the room with me as I explain each and every technique.
Mhm.
So
Yeah.
so they hear how I'm teaching it, so then they can continue on and spread that information in the room as well. So I just really think that and I get it from a business standpoint. Let's make more money. I think during the COVID years, this big company was it had like 200 students in a weekend course all
Yeah.
over the country with their satellite TAs.
Yeah. And it just does not work. It doesn't translate. I hear so much about, even like experienced therapists that were in like a remote satellite group. Like I had to be the TA because we were lost.
Yeah.
There was basically no connection from the main in person or like main instructor. And they were just kind of on their
Wow.
own. And that's not I mean, how do you deem competency, right?
Yeah,
So it's much
right.
harder. It's so much harder to
Yeah.
have these, to promote, to organize, to set up.
Yeah.
But I mean, why are we doing it? Like, the only reason I started teaching is because I was passionate about getting more clinicians out there to do
Yeah.
this work, right?
Right. Right.
We need to feed the field. And
Absolutely.
that's how I could see
And
more clients by getting more trained clinicians.
absolutely. Yeah. And we need to give these new pelvic health therapists treatment options in those introductory courses.
Yes. Yeah, that's my big
Amen.
thing.
Period. Dead stop right there because I know you've heard it and I've heard it in tons of people. Well, I took that first course and I got a lot of theory, but I didn't know what to do. Like I know
Yeah.
how to assess, but I don't know how to treat anything.
Yeah. The
And
intervention. What the heck do we do now?
right. And so if we are having this issue in our field about what is the gold standard, internal work or, not, I think it stems from these therapists not getting the appropriate training in how to actually treat something internally to
Yeah,
be able to be effective.
right.
So if they're not effective in their internal work, and I remember Nicole saying something about, yeah, a therapist said, well, I do the assessment, but nothing ever changes. So why do it? Well, because you don't have the skills. You're
Right.
not learning the techniques that
Yeah.
can make effective change. And I am constantly astounded to this day in how much strength and change I can make in the pelvic floor muscles in one session with my clients because this is the other piece to it. So, my big hills that I'll die on are the pelvic bones need to be addressed prior to doing intravaginal work. We need to address that pelvic outlet. And we need to go beyond just the pelvic floor muscles internally. Like you
Yeah.
teach some bladder techniques. I
Yes.
teach a bladder technique. I teach a cervical technique and working with the cervical ligaments internally. And both of those two are a game changer when it comes to the pelvic floor muscles
Mhm.
because you address the bladder, you address the cervix, the pelvic floor muscles are so much better that
Yeah. I
by the time you work with them, they don't need as much help.
Yeah, Ramona Horton, I've taken her the fascial mobilization of viscera courses, and she says we're not hollow. Like we can't just treat muscles and the bones. Like we got organs. We got these
Yes,
gliding, articulating structures
yes.
with all of the things. So
And
we have to be able to address them, and that's in both the pelvic rehab intro course and the colorectal course. I reached out to her and she allowed me to use certain techniques in the courses. Because
yeah,
it's
you
important.
have,
And I don't think it's
yeah,
necessarily there are advanced ones that you don't want to wait for, but some of the intro, like the bladder, internal and
yeah,
external,
so
that's
easy.
I mean, why
Yeah.
wouldn't we be doing that
Well, that's
in an intro course, right?
exactly. That's what I'm getting at. It's like by just focusing in on the muscles, we're looking at half of the canal. We're
Yeah.
only addressing the half of the canal. If we have to learn to address the anterior wall and the cervix in there and
Yeah.
the endopelvic fascia to address the muscles in there. And so this idea that, these courses are just teaching really assessment of the muscles and that's it. No
Right.
wonder these therapists are going out there going, well, I don't really feel the difference before or after with my internal skills, so why even do it?
Right.
Right?
Because if you think about it, like you're learning to muscle map and you're understanding where you are
Yeah.
within the different pelvic floor muscles. But yeah, that's assessment and that's orientation. but then there's the whole treatment,
treatment
right?
aspect of it.
That
Yes.
comes after it. Like
And
I'm structured for PROMAT. Day one is assessments, internal and external, and then day two is intervention, is treatment.
nice. Yeah. And my 2 day courses are all intervention, external and then internal. And the other thing that is a hill I will die on, I'm dying on a lot of hills here, Laura,
I think we
is
might have
right.
side by side graves.
Yeah, okay. Is the use of the pelvic bones while doing internal work. I teach a
Mhm.
Schulte hold that came to me years ago that I just started doing intuitively. And now that I'm teaching it, it is imperative that we work with the external pelvic bones and while we're doing the internal pelvic muscles or whatever structures we are on, our external hand should be supporting whatever that structure is attaching to. And there is a very simple hold that I teach that just helps the muscles to just like melt. And you don't have to put more force on the muscle. You put more force through the bones. And that's what helps the muscle to relax. And so especially for our clients whose muscles are tender and tenderness really to me is there's something more going on with that muscle. It's not
Yeah.
just that muscle's unhappy. It's like, no, there's a reason it's tender. And once you address the reason, then the tenderness goes away. But the pressure, like I just feel like all we're taught in these earlier courses is just hammer the muscle until it gives up.
Yeah.
And that actually, I really would love the Schulte hold to be taught in every single pelvic health course
Yeah. I
because it's
mean,
so effective.
your work was a big game changer as well. The visceral stuff, because that's, I got started and, with my clients, they lead me to, well, there's something more. I want to
Yes,
know what's in this abdomen
yes,
that I'm working with.
yes,
And then your work with the bones that just really, I mean, it's so great when you can be like, okay, you feel this tension or this tenderness in
yeah,
this pelvic floor muscle. What if I give you this compression and just draw
yeah.
it closer to the origin? And
Yes.
oh my God, that feels so much better.
Oh, and the
Like, well,
clients love
how
it, right?
simple. Yeah.
Yeah, they feel so held with it. So
Yeah.
yeah,
Yeah.
like that. I truly, believe I had a hard time. It took me quite a while to be able to be okay naming it that, because
Hmm.
I'm like, oh, but I really want it to be that's my legacy to pelvic health therapy is like, hey guys, this is how we can incorporate the pelvic bones with the intravaginal work. And I really would love that to be the gold standard as well when it
Yeah.
comes to educating and especially these new therapists coming in.
Yeah.
So,
And I love also adding breath and movement to
yes,
the
yes,
interventions, right?
yeah,
So not just pressing or massaging, but like we're interacting and having a conversation with the nervous system,
yep,
communication, and then can they breathe with it? Can they move their body with it, right? Because like
yep,
I'll have someone like, oh my gosh, that's really intense. And so like, and I like to ease into a little discomfort,
yep,
like find the
yep,
space,
yep,
but I
yep,
always let them know, can you breathe and can you relax around it? If not, it's too much, right? We need
right,
to we
yeah.
need to communicate that because sometimes they'll be like, no, no, if it hurts, that's good,
Well,
right?
sometimes it hurts so good for them, right? Like
Right.
there's
Yes.
some clients who's like, oh my God, that hurts, but it feels so good, keep going. Like
Yeah.
that's okay.
But but I
Yeah.
want to lean into it a little and then see with the breath and the movement, can
Yeah.
we get it to calm down or does it increase? Because
Yes.
then if it's
Yeah.
increasing, like that's how we can figure out if it's too much in the wrong direction
Yeah.
or if it
Well,
does start to calm it down, then we're on the right track.
yeah.
Um,
And
and
Laura,
like
I know
if
you
they
see a,
start to
oh, go ahead.
if they start to move their pelvis, like sometimes,
Mhm.
the breath and they can move their leg, but if they are in control of moving their pelvis with my pressure, that's where a lot of the work comes from, right? They are
Yeah.
moving and it's not just like they're sitting waiting for something to
Right.
happen.
They're not passive in that anymore.
Yeah.
Yeah. I tend to mainly see postpartum and pregnancy clients. You see a little bit of everything, correct, in your
Yes.
practice? I know from the postpartum perspective that there is very rarely does the breath reach the pelvic floor with their breath. I'm
Mhm.
curious in your practice, what you find with your clients as well.
Yeah, I mean, so it depends on like what stage they're at in their reconnection, but that's usually what I have them start right in the
Yeah. Okay.
beginning to
Yeah.
reconnect to, right? Because that's what's
Yeah.
disconnected,
Yeah. Yeah.
is being able to find that core, breathe down into the belly if they're all up in the chest, and
Yeah.
then can they get it down into the pelvic floor and what positions help them reconnect to that? What cues, what like
Yeah.
mid-range postures, just
Yeah.
finding that little glimmer of connection and then building from there.
Yeah. But I think that that's like foundational, right? That's
Yeah,
like one of the
absolutely.
biggest things for no matter what the diagnosis is. So, yeah, cool. Oh my gosh. Anything else? Gold standard for pelvic floor education, pelvic health education.
Yeah,
Anything
I
else
mean,
that you
I
can think
think
of?
like we said, a little recap is understanding when it's appropriate and and that it is really important, right? It just
Yeah.
helps you understand what the baseline is, what you're working with, so then you know how to move forward in a informed
Well,
direction.
Well, and there's these therapists out there that say, well, I can tell you exactly what's going on with their pelvic floor just in the way they're moving. But I have to say, in my practice, Laura, what I thought would be I would find from an external exam and, what I find internally is not always correlated.
No, no. I mean, we can build theories at first, and sometimes
Right.
they're right, but a lot of times you get very different information, or
Yes.
the two sides
Yeah.
of the pelvis are very different. So then you
Right.
know
Yeah. Yeah.
more specifically where you need to
Yeah.
address. So, yeah.
Yeah. All right. So we hope you guys found this helpful. Thank you for listening in. And thank you, Laura, for joining me for this conversation. I absolutely adore everything that you're doing and putting out into the world. And thank you. Laura
Same.
and I are co-presenting at CSM along with Susan Clinton. In February, we'll be at CSM and we're going to be talking about the postpartum bowel. So if you guys are headed to CSM, please reach out and come to see our sessions Friday. We just found out it's Friday at 10:30, so we'd love to see you guys there. And yeah, it's super exciting. It's so wonderful collaborating with you in so many ways, Laura. Thank you.
Always. Yes. Thanks. Take
All
care.
right. Thanks, everybody, for listening in. And we hope that this has spurred your awareness and understanding of doing internal work in a way that is super respectful and honoring to our clients. And let's hopefully turn the tide in the way that we are teaching pelvic health education. Okay. So if you, as a new practitioner, are not liking what you're being offered, it's your job to speak up, and hopefully the bigger companies will change what they're doing. So it's up to us to make that happen, you guys.
Or come
Thanks.
hang out with us.
Yes, exactly. Come take one of our courses. All right, you guys, take care. And here's to smoother births, faster recoveries, and better intravaginal education for pelvic health therapists. Take care, everybody. Bye bye. Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code PODCAST50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.